We're gonna start with Tobey Clark, a friend of ours. He's an expert in clinical engineering, and he works in University of Vermont as a WHO collaborator. We're all ears, and the floor is yours, Tobey.
Thank you, Riyadh, and also Jim. Feel very fortunate to be part of this two-day session. My kind of focus related to HTM innovation, the time of the pandemic, is focused on global HTM and clinical engineering training. So as Riyadh mentioned, I'm from University of Vermont. Right now, it's the land of ice and snow. Next slide, please. So HTM training during the pandemic. Well, we certainly have seen that medical devices are a key element in combating COVID-19, but many challenges exist. As Tedros Adhanom, the Director General of WHO, said back in October, and to be successful, the health workforce not only needs to be ready, not only doctors and nurses with experience in caring for severely ill patients, but also biomedical engineers. So that we're on the map now, and we deserve to be on the map. But the challenges that we faced is the limited availability of devices. I remember back in April that in March, in April, we were searching for ventilators. Our clinical engineering staff found sources for 400 ventilators for our state of Vermont, a very small state. Alternative techniques came into play in evaluation of things like 2 patients on 1 ventilator, emergency use devices, questionable vendors, having to look at new vendors that weren't traditional, and untrained staff. And I'm sure that the LMIC is the hardest hit by these challenges. The value that clinical engineering has shown is certainly represented by the WHO Geneva and the regional offices such as PAHO here in the Americas, IFMBE, and national and state and local is also seeing this. Again, we work very closely with our small state here in the US, Vermont, to assist with preparedness related to sterilization of respirators, the N95 masks, and as I mentioned, ventilators. So HTM training really has to be focused on the requirements. What are the devices? What is the staff level and job function that we're training? And the country context. This training needs to be rapid when we have a pandemic and these emergencies. As you found out, training has gone to virtual, but it still has to be engaging. And there's just one thing that I wanted to focus on here was the fact that, next slide, please, that the data-driven aspect of it. There's what I call a mess of important things over on the left-hand side. You can see that clinical engineers need to know, but don't have that information. Availability, there's no standardization, there's no structure. We've gone from that certainly to putting things in a standardized format as shown in the center of the slide. And doing our conventional reporting and analysis, you know, what's the preventive maintenance completion percentage and what's our inventory and all that. But we really need to get to the next level. And to do that, we have to apply data science and artificial intelligence to develop highly impacting real world solutions. So I'm saying that data science really needs to be part of clinical engineering curriculum and lifelong learning. We're seeing the value of this. WHO, the Medevus project is a great example of that, and other exceptional efforts by Adriana Velasquez and her team to basically use data science to support the battle against the pandemic. Ray Dalton, Tazeen, Lee Bin, Roberto, Fredo Zea, and others, as the list goes on of individuals that are focused on this. So I just wanted to, next slide, please, just give a little bit of background on our department. Next slide. Great. This is a pre-COVID happy family photo of our department. Backup, please. So we're a technical services partnership, part of a university. We're a nonprofit. We've been around since 1973. We have a group of hospitals and clinics and about 55 clinical engineers and biomedical equipment technicians, about a 10-to-1 ratio between those two. Next slide, please. So this is our mantra, really, is our organizational scope goes throughout the planning and management healthcare technology cycle. We want to be able to provide value at the point where physician comes back from the RSNA or from a conference, says we have to have this new technology to meet the standards of care. It cost $1 million, but we need to do that. We want to be able to support the process there through assessment, through looking at replacement of devices, knowing that kind of contributes to the budget, and support the acquisition process, right through the deployment to the management of the technology, education, compliance, maintenance, safety. The gray circles around this, this diagram are basically information collection that we're looking at. And then disposal, things going into the proper waste streams and patient information being destroyed from devices that are taken out of service. Next slide, please. So our collaborating center, pre-COVID, we're really focused on education. We're the only collaborating center in the US that's focused on health technology. So in terms of reference, basically virtual and live training, consultation. We had 2 courses that ran on the PAHO Virtual Campus, Healthcare Technology Planning and Management, and Introduction to Biomedical Technology. We've had live workshops, such as the one in the Caribbean. Our team, it's a relatively small team. We have 3 clinical engineers besides myself, our co-director, Mike Lane. Right now we have 3 student interns and Rosanna Rivas, who's our senior advisor. Next slide, please. So everything changed during the pandemic. Our focus from education went really more to the needs of the pandemic, which was priority medical devices. And this consultation and support of PAHO and WHO first started with what is the priority medical device, what are the new applications looking at different things like the single ventilator for 2 patients, device specifications, reviewing devices. So we've recently done, like for some of the small Caribbean nations, reviewed devices that PAHO had offered to provide for those countries, quality assurance, which is critically important, and of course, training. Really has to be adapted to the context, and training on things such as oxygen concentrators is new for us in that in the US, we don't have that high of a use of oxygen concentrators in hospitals. Of course, when the pandemic started, surge centers, we were buying hundreds of oxygen concentrators to go into those locations. Next slide, please. So one of the primary projects that we're working on is the WHO Video HTM training project. So I've served as a contributor to this project. Initially, we were developing scripts related to that. The initial contributors, Shauna Malawi and Jennifer DeFrancisco, and others, many others. In around November, December, Bill Gentles and myself kind of worked to coordinate the global videographers, and we have a fantastic team of videographers taking videos of going through the various acceptance testing, preventive maintenance, repair of the priority medical devices. And here's a list from about 10 different countries that have contributed. I want to thank all of those. And just Adriana Velasquez kind of sweeping HTM advancement project at WHO, covering very many other different topics. And this is your team's view of about a half or a third maybe of those contributors. Next slide, please. Just a kind of a rundown quickly on some of the training here. I guess I'm not going to go, this is just an example training that we've done globally. I guess the primary points here is it's pretty much all virtual. It consists of courses that we've done, for instance, ESPOL in Ecuador, and working with Mindray to serve 6 or 7 countries in Latin America. Bangladesh, working with Ashnafi, Military Institute of Science and Technology, to provide disinfection training for medical devices. And one that I'm really excited about, which is coming up on March 2nd, beginning, is the Essentials of Biomedical Technology training that we're doing with Health Equity International and the Dalton Foundation. Thank you, Ray, in Haiti. So that will run for 8 months. Next slide, please. Interns, we've had interns since 1973, since the inception of the program, that are primarily trained in clinical engineering. 47 of the recent interns have been global interns from 10 different countries. The last 3 that came here, they offered a high level of support to combat COVID-19, working in the hospital. There was an article in the BIT AMI journal. Unfortunately, it took them 5 to 7 months after the end of their internship to get back to their country. So you can see here's a photo of our university interns working with the international. So the last slide, please. So there's exceptional talents for clinical engineers. It's just amazing, you know, how many different things that we're able to do. It's very broad field. Our value is shown through definitely during this pandemic. We're a jack of all trades. We're juggling a lot of things, but the message is, again, together we can make it better. So thank you.